Imagine checking your blood pressure and seeing a number that would have sent you to the emergency room 10 years ago. Now imagine your doctor looking at that same number and telling you to wait, that it's probably fine. Who do you trust? The machine, the panic in your chest, or the expert who says everything you thought you knew about blood pressure might be backwards? A 74-year-old retired mechanic I'll call Walter sat in my exam room, gripping his knees to keep from swaying. He told me he'd fallen twice that month. His balance was off, he was dizzy when he stood from his recliner, and he was terrified he was having mini-strokes. His blood pressure reading that morning in my office was 128/52. By the textbook, that top number looked like a victory. Controlled. Perfect. But Walter was in danger. His bottom number had fallen into a zone that most people, and even many doctors, never think to check. That 52 was the hidden threat, and it was the reason he was falling. I'm Dr. John Myers. For 22 years, I've specialized in the blood pressure of adults over 60. I've sat across from thousands of patients, confused, frightened, over-medicated, and under-medicated. I've seen the devastation caused by numbers that were treated too aggressively, and the quiet organ damage caused by numbers that were ignored. The guidelines have flipped, changed, and flipped again. And in the middle of all that medical whiplash, one truth has become clear. How we measure blood pressure, interpret it, and act on it is often completely wrong. By the end of this, you will understand your blood pressure better than most doctors have ever explained it to you. You will know exactly which number genuinely puts you at risk after 60, and which numbers are just noise. You'll also learn a hidden calculation that can predict your risk of a heart attack more accurately than either the top or bottom number alone. And you'll discover why a high reading isn't always an emergency, and why a low bottom number might be the silent killer you never saw coming. The question isn't simply, is my blood pressure too high? The real question, the one that actually determines whether you suffer a heart attack, a stroke, or lose your independence, is too high for whom? Too high under what circumstances? And too high compared to what? For a long time, doctors operated under a rule that now seems almost reckless. We were taught a simple formula. Normal systolic pressure equals 100 plus your age. A 70-year-old with a reading of 170 was considered perfectly acceptable. That rule was wrong, and it cost millions of people years of healthy life. It gave them false reassurance while their arteries were being silently hammered. But then the pendulum swung violently in the opposite direction. In 2017, the guidelines changed. Overnight, millions of previously normal adults were reclassified as hypertensive. The definition of high blood pressure dropped from 140/90 to 130/80. Many of those people were over 60, felt fine, and were started on medications they may not have needed. The confusion isn't your fault. It's the result of a medical system that has been rewriting the rules while you were just trying to live your life. Let's start with the basics, because most people get this wrong from the very beginning. Your blood pressure reading has two numbers, but most people only pay attention to one of them. The top number is called systolic pressure. This is the force your blood pushes against your artery walls when your heart beats. When it squeezes, think of it like a wave crashing against a seawall every single heartbeat. That wave hits. The bottom number is called diastolic pressure. This is the pressure in your arteries between heartbeats when your heart relaxes. Think of it as the tide level when the waves pull back, the constant background pressure your vessels live with every second. Both numbers matter, but after 60, they don't matter equally. As you age, your arteries naturally stiffen. They lose elasticity, like an old rubber band. When arteries are stiff, the wave from each heartbeat hits harder because the artery cannot expand to absorb the impact. That is why systolic pressure, the top number, tends to rise. With age, it's not always disease. Sometimes it is simply the physics of aging blood vessels. But the bottom number often does the opposite. As arteries stiffen, they don't recoil as well between beats. So diastolic pressure often stays the same or actually drops after 60. This creates a pattern extremely common in older adults that few have ever had explained to them. It is called isolated systolic hypertension, top number elevated, bottom number normal, or even low. If a 72-year-old walks into my office with a reading of 155/72, their doctor might focus all their attention on bringing down that 155. But the gap between the two numbers is 83. That gap is a signal of arterial stiffness, and it's a sign that their heart is working harder than it should. Now, let's talk about the largest study that changed everything. In 2015, the New England Journal of Medicine published the results of the SPRINT trial. Over 9,300 participants, it was one of the most rigorous blood pressure treatment trials ever conducted. It found that targeting a systolic pressure below 120 reduced heart attack, stroke, and cardiovascular death by 25% compared to the traditional target of below 140. In adults over 75 specifically, the benefit was even more dramatic, a 33% reduction in cardiovascular events. But here's the part that never makes the headlines. Aggressive treatment came with real risks: more fainting, more electrolyte imbalances, more kidney complications, and more falls. In older adults, a fall caused by overly aggressive blood pressure medication can be just as life-threatening as the blood pressure itself. A hip fracture can be a death sentence for an 80-year-old. And that is why there is no single number that is too high for everyone. Your target depends on your age, your overall health, your fall risk, your history, and your body. Here are the numbers I use based on the SPRINT trial, American Heart Association guidelines, and 2 decades of experience. For adults 60 to 75, a systolic below 130 at rest is ideal. 130 to 139 is acceptable if you feel well. 140 to 149 needs monitoring and lifestyle changes, and 150 or above consistently at rest, that is too high. That needs action. For adults over 75, below 140 is the general goal. 140 to 149 depends on how you feel and your fall risk. 150 or above consistently is too high regardless of age. For the diastolic number, below 80 is ideal. 80 to 89 needs watching. 90 or above consistently puts damaging strain on your arteries and organs. But don't stop there. There's a hidden number you can calculate from any reading in 5 seconds. Research shows it predicts heart attack and stroke more accurately than either number alone, especially after 60. It's called pulse pressure. It is the difference between your top and bottom numbers. A reading of 150/70 gives a pulse pressure of 80. A reading of 130/80 gives a pulse pressure of 50. Why does this matter so much? Because pulse pressure directly measures arterial stiffness. Stiffer arteries push systolic higher and let diastolic drop lower. The gap widens, and that widening gap is one of the clearest cardiovascular danger signals in older adults. A landmark study using Framingham Heart Study data found that pulse pressure was a stronger predictor of cardiovascular events than either systolic or diastolic alone in adults over 60. If your pulse pressure is below 40, that's normal. 40 to 60 is acceptable, but worth monitoring. Above 60 is a warning sign of significant arterial stiffness and elevated cardiovascular risk. If your reading is 160/70, most people focus on the 160, but the pulse pressure is 90. That is a screaming alarm that your arteries have lost critical flexibility and your heart is working dangerously hard. And there's another issue almost no doctor discusses: diastolic pressure that is too low. In older adults, a diastolic below 60 is genuinely dangerous. A study in the Journal of the American College of Cardiology found that adults over 60 with a diastolic consistently below 60 had a significantly increased risk of heart attack. Why? Because the pressure between heartbeats was too low to supply the heart muscle adequately. Let's go back to Walter, the retired mechanic from Tennessee. He was on 3 blood pressure medications. His systolic was controlled at 128, which like a victory on paper. But his diastolic had dropped to 52. He was dizzy every time he stood up, and he'd fallen twice. He wasn't having strokes. He was over-medicated. His diastolic was pushed so low that his heart wasn't receiving adequate blood between beats. We reduced one medication carefully. Within 3 weeks, his diastolic rose to 68. The dizziness stopped. The falls stopped. His blood pressure remained controlled. His doctor was so focused on the top number, nobody noticed the bottom had gone dangerously low. Dante, just watch the top number. Don't just watch the bottom. Calculate the gap and make sure the bottom hasn't dropped below 60. Too low can be just as deadly as too high. Now let's talk about measurement, because most people are getting it wrong. And these aren't minor mistakes. They can add 10, 20, even 30 points to your reading. Those false points are the difference between going home reassured and leaving with a prescription you don't need. Mistake number 1, measuring without resting first. You walk into the doctor's office, check in, walk down a hallway, sit on the exam table. Within 60 seconds, the nurse takes your reading. That reading is almost certainly wrong. A study found that blood pressure taken without a 5-minute rest was 10 to 15 points higher than after proper rest. That is the difference between 138 and 148, between acceptable and too high. Mistake number 2, talking during the reading. Research found that talking during a measurement can raise systolic by 10 to 15 points. The nurse asks how you are feeling. You answer, your reading jumps. Nobody connects the two. Mistake number 3, crossing your legs. The same journal found that crossing your legs raised systolic by 5 to 8 points. Stack that on no rest in talking, and you are 25 to 35 points above your true pressure. That is a completely different diagnosis from a completely wrong reading. Mistake number 4, using the wrong arm or wrong cuff size. Blood pressure often differs between arms by 5 to 10 points. Always measuring one arm gives a skewed picture. A cuff that is too small for your arm artificially inflates the readings. That is almost never checked. Mistake number 5, white coat hypertension. This is your blood pressure rising in a medical setting due to anxiety you may not consciously feel. Your body reacts automatically. Heart rate increases, adrenaline releases, pressure spikes. A meta-analysis found white coat hypertension affects 15 to 30% of diagnosed adults. Up to 1 in 3 people treated for hypertension may not actually have it. Their pressure is only high when someone in a white coat measures it. This is why home measurement matters, and why doing it correctly is essential. Here is the protocol I give every patient over 60. Sit quietly for 5 full minutes, feet flat on the floor, back supported, arm at heart level, bladder empty, no talking, no phone, no television. Take 2 readings, 1 minute apart. Use the lower number. Write it down. Do this twice daily, once within 20 minutes of waking, before coffee or breakfast, and once before bed. Alternate arms every other day. Do this for 7 consecutive days. That gives you 28 readings. Average all of them. That average is your true resting blood pressure. Not a single office reading, not a number after rushing across a parking lot. Your actual baseline. If that average is consistently above 150 systolic or 90 diastolic, that is too high and needs attention. If it's 130 to 149, bring those 28 numbers to your doctor. They are worth more than any single exam room reading. Now, one of the most important distinctions you can make: when is a high number an emergency, and when is it just a spike? Here's what most people don't understand. A high number by itself, even a very high number, is not automatically an emergency. You check your blood pressure at home and see 170 over 95. Your first instinct is to panic, call 911, rush to the ER. In some cases, that instinct is correct, but in many cases, That is a temporary spike from stress, pain, caffeine, or anxiety about the reading itself. So how do you tell the difference? The answer is symptoms. A high number without symptoms is a signal to monitor. A high number with symptoms is a signal to act immediately. If your blood pressure is above 180 systolic or above 120 diastolic and you experience any of these, call 911 immediately. Severe sudden headache, unlike anything you have felt before, chest pain or tightness, new or worsening shortness of breath, vision, changes like blurring or partial loss, difficulty speaking or sudden confusion, or numbness or weakness on one side of your body. These indicate a hypertensive crisis. Blood pressure, actively damaging your organs in real time. The brain, heart, kidneys, eyes. A study found that a hypertensive crisis carried a mortality risk of up to 25% within the first year if not treated promptly, 1 in 4. But here's the other side. If your reading is 170/95 and you feel completely fine, no headache, no chest pain, no vision changes, that is not an emergency, that is an urgency. There is a medical difference. Sit down, rest for 5 minutes, breathe slowly, and retake your reading. In most cases, the number drops 15 to 25 points within 10 minutes. If it stays elevated after rest, contact your doctor that day or the next morning. I had a patient I'll call Dorothy, a 68-year-old retired school secretary from Ohio. She called my office in a panic. Her home monitor read 182/98. She was already putting on her shoes to drive to the ER. I asked 3 questions. Headache? No. Chest pain? No. Vision changes? No. I told her to sit down, put her feet up, close her eyes, and breathe slowly for 10 minutes. She called back 12 minutes later. Her reading was 148/84, still elevated, but no longer in crisis range. The first reading came immediately after an argument with her sister on the phone. Her body was flooded with adrenaline. Her true blood pressure was never 182. That was her reactive blood pressure. Dorothy didn't need an ER. She needed 10 minutes and a deep breath. This is the critical lesson. We do not treat single spikes. We treat patterns. One high reading is a data point. 2 weeks of high readings is a pattern. Know the difference, but also know when to act. A number above 180/120 with any of those symptoms, do not wait. Do not rest and recheck. Call 911. That is a genuine emergency, and minutes matter. Blood pressure is not a mystery. It's not a sentence. It's a signal. You now know what most people your age Don T. You know the numbers that matter, the hidden third number that reveals arterial stiffness, the measurement mistakes that fake your reading, and the difference between a spike and a crisis. Understanding your numbers doesn't create fear. It creates power. Power to ask the right questions, measure correctly, know when to act, and know when to breathe. What is your blood pressure today? What is your pulse pressure? Take your reading tonight using the protocol I taught you. Calculate the gap. Share your numbers in the comments. I read every single comment on this channel, and if you have questions, I will answer them. If this video gave you clarity, do 3 things for me. Subscribe right now. We are building a community of people who want to understand their health, not just fear it. Hit the like button. It tells YouTube to show this to more people who need it. And share this with one person over 60 who worries about their blood pressure numbers. You might give them understanding that changes everything. This video is for educational purposes only and does not constitute medical advice. Consult your physician before making any changes to your medications or health routine. I am Dr. John Myers. Take care of your heart because everything else depends on it.